Before 2020, I think if you asked anyone working in public health, or really just any politically aware citizen, to describe the federal health system, they probably would have pictured something like this massive, incredibly sophisticated weather radar system.
Oh, totally. Like this multi-billion-dollar machine.
Exactly. You look at this apparatus, right, the Centers for Disease Control and Prevention of the Food and Drug Administration, the NIH, the Surgeon General's office, and you just assume that the people operating the state-of-the-art machinery don't just have the power to track the storm. You assume they actually have the power to stop the rain.
Right, because we culturally equated surveillance with control. I mean, the American public health infrastructure had spent decades building up this reputation as the premier epidemiological force on the planet.
Yeah, I mean, they eradicated smallpox.
Exactly. They managed the domestic responses to Ebola and Zika. So the assumption baked into the public consciousness was just that because they possessed the instruments to detect a microscopic threat, they naturally possessed the constitutional and operational authority to basically command the weather to clear.
Right. And then the storm actually hit. And what we found out in the most painful, visceral way possible over the course of 3 years is that this massive radar system could really only track the clouds.
Yeah?
It could tell us the rain was falling. It could model how hard it was going to fall. And it could tell us who was getting wet. But it could not legally or operationally control a single drop.
Which was a terrifying realization for a lot of people.
It really was. So welcome to our deep dive into the deadliest pandemic in a century. COVID-19.
It genuinely remains the hardest test the Federal Health Service has ever faced. And what we're exploring today is how a massive systemic crisis revealed the true nature and, honestly, the severe limitations of American public health.
Yeah, because the federal government's real power during a domestic biological crisis wasn't commanding the public.
No, not at all. And the realization we're building toward today is that their ultimate tangible power was actually in deploying their oldest, quietest, and frankly, most overlooked asset.
And to get there, we're opening up a massive dossier of sources for you today. We are looking at historical records, official epidemiological declarations from the CDC and the World Health Organization. We've got extensive U.S. Government Accountability Office reports.
Those really detail the logistical successes and the failures.
Right, and FDA authorization documents. And crucially, we have a first-hand clinical dossier compiled by a physician named Nick, who documented the absolute reality on the COVID wards.
That perspective is so important.
It is, because our mission today is to walk you through the mechanics of what actually happened when the federal system fractured under pressure.
And we should set some ground rules here right off the bat. We are dealing with history that is not only incredibly recent, but intensely personal for almost everyone listening.
Yeah, I mean, the socioeconomic scars are still so visible.
Exactly. And the policy decisions made during those years remain subjects of intense debate. So we are going to be scrupulously fair.
Right, we are not taking sides. We are looking at the mechanics, the structure and the ground-level reality of what happened when that radar system realized it couldn't stop the storm.
We will handle the contested points carefully and just present the strongest, most honest version of multiple viewpoints.
So the expectation of federal control crashed into the harsh reality of the pandemic's first days. And to understand the physics of that collision, we really have to look at the timeline.
Let's start in January 2020.
Right, January 2020. The first confirmed U.S. case lands in Washington state. It's a man in his 30s who had recently returned from Wuhan, China. He presents at an urgent care clinic with a cough and a fever.
And at that specific moment, the virus SARS-CoV-2 was a largely unmapped variable.
We didn't really know what we were dealing with yet, did we?
Well, we knew it was a novel coronavirus. We knew it was genetically related to the virus that caused the SARS outbreak in 2003, but its transmissibility and its clinical profile were still being pieced together in real time.
And then the Department of Health and Human Services recognizes the escalating threat. They declare a public health emergency on January 31st, 2020.
Which is the bureaucratic trigger that is supposed to mobilize the entire federal response apparatus.
Right. And then by March 11, the World Health Organization looks at the global spread and officially declares it a pandemic.
But before we get into the operational response, I think we need to look at the science of where this virus actually originated, because our sources highlight the origin of SARS-CoV-2 as a major area of ongoing scientific debate.
Yeah, let's unpack that, because it is a very contested issue.
It genuinely is unresolved among serious virologists and intelligence agencies. You basically have two primary, well-documented hypotheses.
Okay, what's the first one?
The first is a natural zoonotic spillover. This posits that the virus jumped from an animal host to a human, likely in the Huanan seafood wholesale market in Wuhan.
Which is a pretty common biological phenomenon, right?
Yeah, very common. Pathogens routinely cross the species barrier when humans and dense populations of stressed wildlife are brought into really close contact. I mean, that is exactly how previous coronaviruses like SARS and MERS emerged.
Nature basically has a massive open-air laboratory and millions of years of experience producing devastating viruses without any human intervention whatsoever.
Exactly. But the second hypothesis is a laboratory-related incident.
Right, the lab leak theory.
Right. This suggests that the virus, whether it was naturally collected from a bat cave or actively being studied, accidentally leaked from a virology lab in Wuhan, which is a city that just happens to host China's premier coronavirus research facilities.
And a lab accident isn't some crazy conspiracy theory either, right? I mean, that's a documented occupational hazard.
Oh, absolutely. There is a long history of pathogens escaping high containment laboratories due to faulty protective equipment or improper waste disposal, or just a researcher unknowingly becoming infected and literally walking out the front door.
So both scenarios represent severe systemic vulnerabilities. One is ecological and one is occupational.
Exactly. The definitive origin remains a highly debated scientific question, but neither scenario requires a grand conspiracy. They are both just stark realities of modern biology.
Well, regardless of the origin, the virus was circulating in the United States by January 2020. And this brings us to the first critical execution failure. A stumble that our sources argue really set the tone for the entire pandemic.
Yeah, this is where things start to go wrong operationally.
The CDC, which was long considered the absolute gold standard of global public health, rolls out its initial diagnostic test kits in February. And the rollout is an unmitigated disaster.
It really was, and to understand the magnitude of this failure, we have to look at the actual mechanism of the test itself.
Let's get into the weeds a bit here.
So the CDC opted to design a real-time reverse transcription polymerase chain reaction test, or
RT-PCR.
Right, PCR, we all heard that a million times. But what does it actually do? PCR is essentially a molecular photocopier. It takes a tiny microscopic sample of genetic material and uses repeated cycles of heating and cooling along with specific enzymes and chemical primers to amplify that genetic material.
So it just copies it until there's enough of it to detect.
Exactly. You are looking for a highly specific needle in a haystack. So you build a machine that duplicates the needle millions of times until the haystack is literally made of needles.
That is a great analogy. So how do you make sure the test is actually accurate?
Well, you design it with multiple probes. Think of them as genetic search warrants that look for different parts of the virus's genome. The CDC's initial test kit had 3 of these probes.
Okay, 3 probes.
And it also included a negative control. This is a well that contains absolutely no viral material. It's used to prove that the testing environment isn't contaminated.
So if the negative control lights up, it means something is wrong with the test itself.
Right. If the negative control lights up, the test is completely invalid. So when the CDC shipped these kits to state and local public health laboratories across the country in early February, the labs immediately hit a wall.
Because the 3rd probe, the N3 probe, was triggering false positives, right?
Exactly. The negative control logs were lighting up. The reagents were flawed, likely due to a contamination issue during the manufacturing process at the CDC's own facilities.
Which is mind-blowing. I mean, a technical error in a laboratory setting happens all the time. I get that. But this specific error triggered a massive regulatory cascade.
It was a perfect storm of bureaucracy. Because of the Public Health Emergency Declaration, the FDA's emergency use authorization rules were in effect.
The EUA rules.
Right. And this meant that clinical laboratories, university hospitals, private testing companies, they couldn't simply invent their own tests, which are known as laboratory-developed tests, or LDTs. They couldn't just start using them.
Wait, so they couldn't even use the testing protocol that the World Health Organization had already published and distributed globally?
No, they legally could not. They were legally required to use the FDA-authorized CDC test.
So you have this strict regulatory bottleneck squeezing a completely flawed scientific product.
Exactly. State lab directors were looking at their CDC kits, seeing the negative controls fail, and they legally could not report out the results of the other 2 functional probes.
That is so frustrating.
They couldn't bypass the failed N3 probe without FDA permission, and they couldn't build their own workarounds.
So what did they do?
The bureaucratic rigidity meant that for weeks, state labs had to box up their patient samples and physically mail them to the CDC headquarters in Atlanta to be tested.
Think about the logistical nightmare of that. You have a highly contagious respiratory virus. Speed is literally the only weapon you have for containment. You need to identify a case, isolate that person, and trace their contacts within hours.
Right, hours, not days.
And instead, doctors are taking swabs, packing them in dry ice, putting them on FedEx planes, and waiting a week for a result from Atlanta.
It completely paralyzed the response. While other nations like South Korea or Germany, who had rapidly decentralized their testing and utilized private labs, were actively tracking the virus's spread and isolating clusters, the United States experienced a period of critical epidemiological blindness.
We just couldn't see it.
We're flying blind. Throughout the entire month of February and into early March, the virus was spreading completely undetected. It was silently seeding itself in nursing homes in Washington state, in the transit hubs of New York City, and communities across the Sun Belt.
And by the time the FDA finally relaxed the rules in late February to allow clinical labs to develop their own tests and the CDC fixed their kit, the math had already defeated us.
The containment window hadn't just closed the house, was actively engulfed in flames.
We went from trying to keep the virus out to suddenly trying to figure out how to keep hospitals from collapsing.
And that technical failure did more than just cost the nation crucial weeks of response time. It created a profound deficit of institutional trust.
Which is a huge theme in our sources.
It is. The CDC was the agency that had quite literally written the textbook on outbreak response. For them to stumble right out of the gate, to fail at the fundamental task of designing a functional PCR test, permanently damaged their credibility with both the public and state-level officials.
I mean, think back to our radar analogy. If the weather radar operators miscalibrate their instruments and fail to warn you about a Category 5 hurricane until your living room is underwater, you are going to be incredibly skeptical of their advice on how to rebuild the house.
Exactly. And the cascading effect of that lost trust brings us to the deepest structural theme of the pandemic.
Right, power divided.
Yes. Because containment failed, the strategy had to shift immediately to mitigation. We had to slow the virus down to prevent total systemic collapse. But the moment we shifted to mitigation, we ran headlong into the constitutional architecture of American public health.
So let's talk about the myth of the federal lockdown. Because you still hear this in retrospective analyses and political debates. People will say, well, the federal government locked down the country.
Yeah. And structurally, legally, and historically, that is a completely false statement.
Okay, let's unpack that. Why is it false?
The federal government possesses immense regulatory power over interstate commerce, border security, and federal lands. But the general police power, the constitutional authority to bind the public to legally force a local restaurant to close its doors or compel a citizen to stay in their home or mandate the wearing of a medical device like a mask.
Or who have that power?
That belongs entirely to the states under the 10th Amendment. The CDC, the Surgeon General, the White House Coronavirus Task Force, they could only issue guidance.
They couldn't force anyone to do anything.
No, they could publish white papers recommending social distancing. They could advise governors that closing bars would reduce transmission. But they couldn't order it.
Okay, wait, I want to challenge that limitation because living through it, it felt like the federal government was doing a lot more than just advising. What about the CDC eviction moratorium? Or the OSHA mandate that attempted to force large employers to require vaccines or weekly testing?
It's a fair question.
Because the federal government absolutely tried to use federal police power to mandate behavior.
That is a vital distinction, but look at the mechanism they had to use to attempt it. Because they lacked a direct constitutional lever for public health mandates, they had to reverse engineer their authority using centuries-old administrative statutes.
What do you mean reverse engineer?
Well, for example, the CDC attempted to halt nationwide evictions by stretching a provision in the 1944 Public Health Service Act. That act was originally designed to allow the quarantining of specific infected individuals or the fumigation of properties to stop the spread of communicable diseases.
Oh, wow. So they tried to use a fumigation law to stop evictions.
Basically, they argued that evicting people would force them into crowded shelters, thus spreading COVID.
And the Supreme Court eventually struck that down.
Precisely because that power historically and legally belongs to the states. The court ruled that the CDC had vastly exceeded its statutory authority.
And the same thing happened with the OSHA employer mandate, right?
Exactly. OSHA regulates workplace safety like hard hats or exposure to toxic chemicals. The administration tried to argue that a circulating airborne virus constituted a specific workplace hazard that allowed them to mandate vaccines for 84 million private sector employees.
And the Supreme Court blocked that as well.
Yes, ruling it was a broad public health measure disguised as an occupational safety standard.
So the federal government was essentially trying to use a wrench as a hammer because they didn't legally own a hammer.
That is exactly right. The only people holding actual hammers were the 50 state governors and thousands of local mayors.
And this architecture of divided power isn't new, right? Our sources draw a direct line back to the 1918 influenza response.
The 1918 response looks functionally identical to 2020. A century ago, the federal government couldn't mandate closures either. The response was entirely localized.
Give me an example of how that played out back then.
Well, Philadelphia decided to move forward with a massive Liberty Loan parade packing hundreds of thousands of people into the streets, while St. Louis decided to aggressively close schools, theaters, and ban public gatherings before the virus took hold.
And the outcomes were wildly different. Philadelphia experienced a catastrophic spike in mortality, with bodies literally stacking up in the streets because the morgues were full, while St. Louis managed to significantly blunt the initial wave.
Right, so we faced a novel microscopic threat in 2020 using the exact same constitutional framework from 1918. We did not have one national pandemic response.
We had 50.
We had a patchwork of 50 different pandemic responses constantly shifting based on state politics, local healthcare capacity, and even seasonal variations in viral spread.
Which brings us to the agonizing ledger of non-pharmaceutical interventions, or NPIs. The lockdowns, the school closures, the mask mandates.
These were the only tools available in the spring of 2020.
And public health officials weren't just guessing. They were looking at complex mathematical models like the ones produced by Imperial College London, which projected millions of deaths if the virus was allowed to spread unchecked.
The models highlighted the terrifying math of the ICU cliff. The goal of NPIs was to, quote-unquote, flatten the curve, a phrase that became ubiquitous.
Yeah, we all remember flatten the curve.
But the underlying mechanism of flattening the curve was about healthcare triage. If a virus has a basic reproduction number, or R0, of 2.5, meaning one infected person infects 2.5 others on average, the growth is exponential.
So if the virus burns through a city in 3 weeks instead of 3 months, you get a massive spike in severe cases all at once.
Exactly. And every hospital system has a hard ceiling on capacity. A finite number of intensive care beds, ventilators, and specially trained critical care nurses.
And when a hospital hits 100% capacity, the mortality rate doesn't just rise for COVID patients.
No, it spikes exponentially for everyone. If you have a severe car accident or a heart attack or a stroke and the local ICU is physically full of COVID patients on ventilators, you might die in the hallway waiting for a bed.
Which is horrifying.
It is. So the primary argument for lockdowns was to blunt that exponential spike and prevent a catastrophic systemic collapse of the medical infrastructure.
It was a blunt, devastating instrument used to buy time. But the other side of that ledger holds costs that were equally devastating and undeniable.
Absolutely.
I mean, economic destruction of small businesses forced to close their doors indefinitely, hourly workers losing their livelihoods overnight, leading to a massive spike in food insecurity.
And the impact of school closures is perhaps the most heavily weighted item on that side of the ledger. We're looking at severe, well-documented educational setbacks, particularly for lower-income students who lacked access to reliable internet or parental supervision for remote learning.
Plus, there was a profound spike in pediatric mental health crises, anxiety, and depression due to the prolonged social isolation of an entire generation of children.
It was an incredibly difficult balance. Public health officials, governors, and mayors were forced to balance these two catastrophic risks in real time, often with incredibly incomplete data.
And because of federalism, the choices they made varied wildly depending on where you lived.
Right. If you lived in Florida or Texas, your local government might have prioritized economic and educational reopening much earlier. If you lived in California or New York, the focus remained heavily on aggressive mitigation and prolonged closures.
The psychological toll of that geographic fragmentation just cannot be overstated. I mean, if you can drive 20 minutes across a state line and go from a jurisdiction where schools are closed and restaurants are boarded up to a jurisdiction where malls are packed and kids are playing high school football, public health guidance begins to look entirely arbitrary.
It feels less like objective virology and more like a geographic lottery based on voter registration.
Exactly. And that fragmentation hyper-accelerated the political polarization of the virus.
And to really understand what it felt like while this political and geographic fragmentation was happening, we need to look at the clinical dossier provided in our sources by Nick.
Nick, the physician who was treating patients on the COVID wards during these chaotic early waves.
Yes. Nick's firsthand accounts cut right through the abstract policy debates. His reflections document a profound cognitive dissonance.
Yeah, he describes the physical reality of the hospital floor, the suffocating heat of wearing full personal protective equipment that he was forced to reuse for days due to severe supply chain shortages,
He describes the relentless rhythmic alarm of the ventilators.
and the emotional toll of holding an iPad so a family could say goodbye to a dying relative over FaceTime because visitors were strictly banned from the hospital.
He's living in this localized war zone, and then he walks into the break room, sits down, and looks at the television. He watches federal press conferences where agencies are debating the nuances of transmission metrics or arguing about the definition of essential businesses.
And he notes how entirely disconnected the federal apparatus seemed from the reality of the ICU.
He describes a profound sense of abandonment on the front lines. The federal agencies are issuing dense, sometimes contradictory PDF guidelines on ventilation and distancing, while Nick and his colleagues are frantically trying to figure out how to convert a post-op recovery room into an overflow ICU because the emergency department has 20 patients holding for admission.
The federal system was functioning as an advisory think tank, while the local clinical systems were absorbing the actual physical impact of the biological storm.
And the realization quickly dawned on everyone, from the physicians on the floor to the economists looking at the GDP numbers, that we could not simply distance mask or lock down our way out of the pandemic permanently.
Right, the social, economic, and psychological costs were just utterly unsustainable.
The only universal way out, the only way to fundamentally change the math of the virus, was to change the biology of the host. We needed to make the population immune.
And that operational necessity pivots us to the race for a vaccine. And this is where the narrative shifts significantly. This is where we see the federal government actually leverage its immense power, not through behavioral mandates, but through financial and logistical engineering.
This brings us to Operation Warp Speed.
Right. Operation Warp Speed launched in May 2020. It was a massive, unprecedented partnership between the Department of Health and Human Services and the Department of Defense. Let's look at the financial mechanism of this, because normally bringing a novel vaccine to market is a process that takes 5 to 10 years, sometimes longer.
Yeah, the traditional bottleneck in vaccine development is rarely just the bench science. It is the immense financial gravity of the clinical trial process.
So how does it normally work?
Normally, a pharmaceutical company develops a candidate, conducts a small phase 1 safety trial, and then waits for the data. If the data is promising, they pitch investors or their board to raise the capital for a larger phase 2 efficacy trial.
And that takes time.
It takes months. They wait months for those results. If they look good, they raise hundreds of millions of dollars for a massive phase 3 clinical trial.
It's like they were building a skyscraper one floor at a time. You don't pour the concrete for the 50th floor until the city inspector approves the 49th.
Exactly, because if the inspector fails you and you've already built the top floors, the company goes bankrupt. You don't spend $500 million building a sprawling manufacturing plant to produce the vials until the FDA has officially approved the drug.
But Operation Warp Speed changed the physics of that process entirely, right?
They did it by entirely removing the financial risk. The federal government stepped in as the ultimate venture capitalist. They said to the pharmaceutical companies, build all 50 floors of the skyscraper simultaneously.
Just build the whole thing at once.
Right. We will fund the research. We will fund the massive phase 3 clinical trials, and most importantly, we will pre-purchase hundreds of millions of doses right now before we even know if the vaccine works.
So they paid for the manufacturing plants to start churning out millions of vials of experimental vaccine while the clinical trials were still actively running.
Yes. If the data showed the vaccine failed, the federal government simply threw the vials in the incinerator and absorbed the multi-billion-dollar loss.
But if the data showed it succeeded,
If it succeeded, millions of doses were already sitting in refrigerated warehouses ready to be loaded onto FedEx and UPS trucks the very morning the FDA granted the emergency use authorization.
which is just brilliant logistics, it eliminated the sequential financial waiting game and compressed years of logistical planning into months.
But let's look at the science they were funding, because the underlying technology is a crucial part of our story. We are talking primarily about mRNA technology. Messenger RNA.
Right. And for decades, the traditional method of making a vaccine involved growing massive vats of a virus, often in millions of chicken eggs, and then chemically killing or weakening the virus before injecting it into a person so their immune system could recognize it.
Which is effective, but it's incredibly slow and clunky. mRNA technology is fundamentally different. It basically acts as biological software.
Biological software, how so?
Instead of injecting the actual virus, the Pfizer-BioNTech and Moderna vaccines, use a tiny snippet of genetic code wrapped in a lipid nanoparticle.
Which is essentially a microscopic bubble of fat to protect it, right?
Exactly. When injected, this mRNA enters your muscle cells and provides a temporary set of instructions. It basically says print the spike protein.
And the spike protein being the little crown-like structures on the outside of the SARS-CoV-2 virus that it uses to pick the lock and enter human cells.
Correct. So your own cells manufacture just the spike protein, not the whole virus, so it can't make you sick. Your immune system sees this foreign protein, flags it as an invader, and learns how to build antibodies to destroy it.
And then the mRNA just goes away.
Yep. Once the immune system learns the profile, the mRNA degrades and disappears. When the real virus shows up later, your immune system already has the wanted poster and the weapons ready.
And the speed of this was staggering. The genetic sequence of the virus was published by researchers in January 2020. Within days, Moderna had finalized the sequence for their mRNA vaccine candidate.
But notice the key detail in this triumph. The defining science of the pandemic response did not come from within the old public health service.
Right. The CDC did not invent the vaccine.
The NIH funded research, but the foundational breakthroughs for the mRNA platform and the lipid nanoparticles were the fruit of decades of iterative work in academic institutions and private pharmaceutical laboratories.
The science was borrowed. The federal government acted as the financier and the logistical distributor, but the actual innovation was external to the federal public health agencies.
Nevertheless, the outcome was a genuine medical marvel. On December 11, 2020, less than a year after the novel virus was identified, the FDA issued the first emergency use authorization for the Pfizer-BioNTech vaccine.
And Moderna followed a week later.
The clinical trial data demonstrated a profound, highly documented reduction in severe disease hospitalization and death among those who received the vaccine.
But here's the thing. Having a miracle cure in a glass vial is only half the battle. You have to convince people to let you put it in their arms.
And that is where the narrative hits a wall.
Yeah, the scientific triumph of warp speed slammed directly into the sociological reality of a fractured, exhausted, and highly suspicious nation.
The empirical facts of the vaccines, their documented efficacy against severe outcomes, became almost immediately entangled with deeply contested public policies.
The rollout itself was a logistical masterpiece utilizing the military and private sector supply chains. But the uptake split drastically along the familiar lines of geography, political affiliation, and prior confidence in institutions.
If we go back to the geographic lottery of the MPIs, if you lived in a community that felt bound by the shifting, sometimes contradictory guidance on masks, or if your family's business was destroyed by prolonged economic lockdowns, your baseline trust in the federal health apparatus was likely at rock bottom.
And when that same apparatus shows up a year later, aggressively promoting a brand new, fundamentally novel genetic vaccine, that skepticism doesn't just magically disappear.
No, it doesn't. And that skepticism was further inflamed by the policies surrounding the rollout. The debate over vaccine mandates for employment, whether hospitals, schools, or private businesses could fire employees who refused the shot, became explosive.
And then there was the push for widespread boosters in lower-risk populations like healthy young adults and children, while global supply was still constrained.
Right, that sparked intense, legitimate debate even among virologists and public health experts. And the messaging strategies used by officials often lacked nuance, presenting evolving science as absolute certainty.
Which paradoxically fueled more distrust when the guidance inevitably had to change as the virus mutated into variants like Delta and Omicron.
We had engineered the most sophisticated biological shield in human history, but the federal government lacked the persuasive capital to convince a large portion of the population to pick it up.
The science was borrowed, the persuasion was missing, and the federal voice was largely ignored or viewed as purely advisory by millions of citizens. It really paints a picture of a federal health system that is brilliant at funding external science, but entirely toothless when it comes to operational public health on the ground.
Which brings us to the core thesis of this deep dive, because the assumption that the federal health system was operationally toothless is actually incorrect.
Okay, let's get into this because this is fascinating.
While the CDC was taking an absolute public battering, while the models failed to predict human behavior, and while the debates over mandates raged in the courts, there was one entity, one highly specific group that the federal government could directly command.
The oldest part of the public health service did exactly what it was designed to do.
Yes. This is the centerpiece of the pandemic narrative that almost entirely escaped the daily news cycle.
The United States Public Health Service Commission Corps. They mounted the largest, most sustained deployment in their 223-year history.
So the Commissioned Corps is one of the 8 uniformed services of the United States. They are commanded directly by the Surgeon General. They wear uniforms nearly identical to the United States Navy, complete with ranks and insignias, but they are an entirely unarmed service composed exclusively of highly trained public health professionals.
We're talking about physicians, specialized nurses, infectious disease scientists, environmental health engineers, pharmacists, and epidemiologists.
And they trace their lineage all the way back to 1798, when President John Adams signed an act to provide care for sick and disabled seamen, establishing the Marine Hospital Service.
So their original mandate was to prevent infectious diseases like yellow fever and cholera from entering the young nation through its bustling port cities.
They were the original tip of the spear for American quarantine and containment, and in 2020 that historical mandate was activated on an unprecedented scale.
Out of approximately 6,100 active duty officers in the Corps, more than 4,500 were deployed during the COVID-19 response. Think about the sheer percentage of that mobilization.
It's massive. The vast majority of the entire service was pulled from their regular duties at agencies like the FDA, the NIH, or the Indian Health Service, and ordered directly into the breach.
And look at the structural paradox here. The Surgeon General of the United States, operating out of Washington, D.C., did not have the legal authority to order a single state governor to close a single restaurant or mandate a single mask.
Right.
But that same Surgeon General possessed the absolute statutory authority to order thousands of uniformed medical officers to pack their sea bags, leave their families indefinitely, and march directly into the most dangerous, highly infectious, biological hot zones on the planet. And they had to go.
They were the ultimate federal surge capacity. To understand the reality of what they did, we have to look at the environments they deployed to.
Let's start in February 2020, before we even truly understood the airborne nature of the virus.
Yeah.
The Diamond Princess cruise ship.
The ship was docked in Yokohama, Japan, with an exploding outbreak of COVID-19 on board. The Japanese government had quarantined the vessel, trapping thousands of passengers and crew inside what effectively became a floating incubator.
The virus was just spreading rapidly through the ship's shared ventilation systems and close corridors. It was an epidemiological nightmare.
So Commissioned Corps officers were mobilized and flown to Japan to manage the crisis. They had to board a contaminated vessel, establish hot and cold zones to prevent cross-contamination triage, critically ill patients conduct mass testing in incredibly constrained spaces, and orchestrate the highly complex biosecure evacuation of hundreds of American citizens back to quarantine facilities in the United States.
And they were operating in an entirely novel threat environment, relying just on their training in infection control and crisis logistics.
And it wasn't just international cruise ships. When the virus established a foothold, domestically local healthcare systems in major metropolitan areas began to buckle.
So the Corps was sent into overwhelmed hospitals in cities like New York and Detroit. They arrived in emergency departments where patients were overflowing into the hallways and waiting rooms where the local staff was literally decimated by illness and exhaustion.
They integrated into the ICUs, providing direct clinical care, managing ventilators, and reinforcing the collapsing infrastructure.
We also have to look at their deployments to nursing homes and long-term care facilities.
Yes. In the early waves of the pandemic, before vaccines, nursing homes were the absolute epicenters of mortality. The virus swept through these facilities with devastating lethality.
And local staff were terrified, often lacking basic PPE, and the facilities were structurally incapable of handling airborne isolation.
So Corps officers, specifically environmental health officers and infection prevention specialists, were deployed directly into these facilities. They assessed HVAC systems, redesigned patient flow to separate infected residents, trained the remaining staff on proper PPE usage, and provided acute care to the most vulnerable demographic in the country.
And perhaps the most staggering logistical and geographic deployments were to tribal lands.
The Navajo Nation, which spans across Arizona, New Mexico, and Utah, covers a landmass roughly the size of West Virginia.
And early in the pandemic, they suffered some of the highest per capita infection and mortality rates in the entire United States.
The vulnerabilities there were multifaceted. You have vast geographic distances, making access to acute care incredibly difficult. You have high rates of underlying conditions like diabetes and hypertension. And crucially, a significant percentage of homes on the reservation lacked indoor plumbing and running water, making the basic public health advice of wash your hands frequently a near impossible logistical hurdle.
So the Commission Corps mobilized massive resources to the Navajo Nation. They didn't just augment existing clinics, they rapidly established alternative care sites in field hospitals and high school gymnasiums and community centers to handle the overflow of patients.
They brought in mobile medical units. Later in the pandemic, when the vaccines became available, they were instrumental in driving the distribution across those vast, medically underserved landscapes, organizing mass vaccination drives that required precise cold chain storage logistics right in the middle of the desert.
They were also heavily deployed to the southern border. They managed severe health crises in crowded immigration detention facilities and processing centers where physical distancing was a physical impossibility.
They set up medical screening protocols, managed isolation units within the facilities, and provided direct care to detained populations.
Everywhere the system was fracturing, everywhere local resources were exhausted. The Commission Corps was the spackle trying to hold the walls together.
There is a profound contrast here that really defines the era. On cable news, you saw a constant loop of federal public health authority fraying. You saw politicians pointing fingers, agencies issuing confusing data, and endless debates over masking guidelines.
But underneath all that noise, the Silent Service was quietly, efficiently, and relentlessly executing its mission. They didn't have the luxury of going on television to debate the nuances of federalism. They had crashing patients in front of them who needed to be intubated.
They functioned as a highly mobile, highly disciplined medical shock troop, but their deployment reveals the precarious architecture of our national security.
How so?
If you look at the scale of the United States, a nation of over 330 million people spread across a massive continent, our ultimate public health safety net, the very last line of defense when local and state systems fall apart, relies heavily on a uniformed service of roughly 6,100 people.
Wow, when you put it like that, it is sobering. And despite their heroic, unprecedented deployment, despite the officers working grueling shifts in biohazard gear across the country, the sheer scale and biological math of the virus ultimately overpowered the system.
The Corps held the line in the specific battles they were sent to fight, but they could not stop the tide of the broader war.
And that leads us to the grim reckoning of the pandemic's toll. We have to address the human scale of this tragedy.
Because all the complex policy debates over MPIs, all the logistical miracles of Operation Warp Speed, and all the tactical deployments of the Commission Corps culminate in a mortality figure that is almost too large for the human mind to truly comprehend.
Roughly 1.2 million Americans died.
It stands as the worst mortality event in modern United States history, surpassing the estimated death toll of the 1918 influenza pandemic and the combat deaths of all 20th century American wars combined.
And our sources note that even this staggering number, 1.2 million, is the subject of complex epidemiological tracking and genuine differences in counting methods.
Yeah, there is a debate over how we count. Some researchers look strictly at death certificates where a physician listed COVID-19 as the underlying or primary cause of death. Others rely on excess mortality modeling, calculating the total number of people who died during the pandemic years from all causes and comparing it to the historical average of previous years.
The excess mortality argument suggests that many early COVID deaths went completely unrecorded because we lacked testing capacity.
Right. It also accounts for the secondary casualties of the pandemic, the people who died from preventable heart attacks or delayed cancer screenings because the healthcare system was completely overwhelmed.
And these varying figures are not the result of some conspiracy to inflate or deflate the severity of the virus. They are simply an artifact of a highly decentralized, complex medical coding system attempting to track a mass casualty event in real time across 50 different state jurisdictions.
Whether the exact biological number is slightly higher or lower, the societal magnitude is undeniably catastrophic.
And we have to look clearly at who bore the brunt of those numbers. The virus was novel, but the societal fault lines it exploited were ancient and deeply entrenched. The mortality did not fall evenly across the population.
No, it did not. It fell vastly disproportionately on the elderly. It devastated poor and historically underserved communities.
The ability to mitigate risk was largely determined by socioeconomic status. The laptop class could transition to remote work, order their groceries for delivery, and isolate in comfortable homes.
Essential workers, meatpacking plant employees, grocery clerks, transit workers, nursing home aides could not zoom into work. They had to physically enter the high-risk environments every day.
Furthermore, multi-generational households living in cramped conditions facilitated rapid viral spread within families.
And populations with higher rates of pre-existing conditions like obesity, diabetes, and heart disease, often the result of decades of structural health disparities, took the hardest clinical hits when infected.
As the virus mutated into less virulent strains, and as population-level immunity built up through a combination of mass vaccination and widespread natural infection, the immediate crisis slowly began to recede.
On May 11, 2023, the federal government formally ended the COVID-19 public health emergency.
The crisis phase was officially over, but the reckoning for the institutions involved was just beginning.
The Centers for Disease Control and Prevention emerged from the pandemic fundamentally diminished in the eyes of the public. The critiques came heavily from every side of the political spectrum.
But to understand the path forward, it is vital to distinguish between the two distinct categories of failure that drove this criticism.
Yes. First, there were the execution failures. These are the operational mistakes the agency actually owns.
Right, like the botched rollout of the initial PCR test kits in February 2020.
The clunky, outdated data reporting systems that couldn't track hospital capacity in real time.
And the public messaging that frequently seemed contradictory, overly academic, or entirely detached from the daily realities of a frightened public trying to navigate risk.
Those are internal operational failures of the agency's leadership and structure. But the second category involves structural limitations, failures born of misplaced expectations.
A significant portion of the public anger directed at the CDC was based on the false assumption that they possessed the power to command the weather.
People were furious at the CDC for the economic devastation of business closures, or conversely furious at them for not enforcing mask mandates strongly enough in certain states.
But as we've explored, the CDC had no actual constitutional command authority over the states. They were an advisory body, being blamed for the actions of state governors, or blamed for their inability to control the actions of those governors.
They were expected to act like a general, but legally they were only allowed to be a consultant.
And the post-2023 landscape is defined by deep institutional introspection. There are massive internal reviews underway at the CDC. There are widespread proposals for restructuring the agency to make it more operationally agile, focusing less on academic data gathering and more on rapid tactical outbreak response.
But the far more concerning metric is the broader societal retreat from public health trust.
We are seeing a measurable decline in routine childhood immunizations for diseases like measles and polio. The intense polarization of the COVID vaccines has bled over into a general skepticism of the entire public health enterprise.
It leaves us with a massive, unresolved question. How does a country recover its baseline trust in public health when the institutions themselves are fundamentally questioning their own structure, authority, and competence?
We have to ask how history will record this era. Is COVID-19 remembered as the moment the system was overwhelmed by an impossible task? A once-in-a-century viral storm that no amount of preparation or radar could have fully contained?
Or is it remembered as the moment the system revealed how hollow and fragmented its central authority had actually become?
The reality of the dossier we've unpacked today suggests the answer is both. The deadliest pandemic in a century proved that the Federal Health Service is a profound paradox.
It showed the federal health establishment at its most and least powerful at the exact same time. Its greatest scientific triumph, the rapid development and deployment of the mRNA vaccines, relied heavily on borrowed science and external innovation.
Its authority to protect the public from an airborne pathogen was legally restricted to merely offering advice with the real bruising command decisions, resting with state governors and local mayors in a fractured 50-state patchwork.
Yet amidst the fraying authority, the bitter political divisions, and the public battering of massive agencies like the CDC, the Commission Corps, stood apart.
They were the one concrete asset that could actually be ordered forward into the void. They mounted the largest deployment in their history, running directly into the biological fire while the bureaucratic system around them fractured.
They answered the call exactly as they had been trained to do since 1798. They are the tangible proof that when the advisory systems fail, the federal government's ultimate response is a physical one, deploying trained professionals to triage the collapse.
I want to thank you for joining us on this incredibly intense journey through our very recent history. We all live through this. And sometimes the hardest history to truly understand is the history you just survived.
The trauma obscures the mechanics.
It really does. But understanding the actual operational architecture of what happened, the devastating testing failures, the constitutional reality of divided power, the miracle of borrowed science, and the heroic sacrifice of the silent service is absolutely crucial to surviving whatever comes next.
Because the biology of the planet guarantees there will be a next time. The viruses are always circulating, mutating, and looking for a new host. The radar will eventually detect another storm.
Which leaves me with a final thought for you to mull over as we close out this deep dive. We started by visualizing that massive weather radar system, realizing it could only track the clouds, not control the rain. If the defining operational lesson of COVID-19 is that the federal government cannot mandate our behavior to stop a pathogen, but can only supply the finance science and deploy a few thousand uniformed officers to the hardest-hit disaster zones, what happens when the next crisis arrives? What happens when the next virus moves faster than the mRNA platforms can adapt and requires an immediate unified behavioral response that science alone cannot solve? If the silent service of the Commission Corps is truly our last line of defense, a thin line of 6,100 people protecting a nation of 330 million who is making sure they're ready for the next time the radar goes dark.